Okay, now we're recording. All right, so we talked about infectious disorders. Now we're going to move on to restrictive disorders. So I think you guys understand like infection, right? Hope so, because we talked about it last quarter. But then restriction is anything that's either putting pressure or reducing how the lungs are able to expand and receive air. Or reduce compliance as well. Sorry, I think I have to click on the right clicky thing to get it to go. There we go. So pleurisy or pleuritis. Usually you're going to see pleuritis as the more common. And that's the infection of that pleural cavity. Usually there's some fluid that's there. So when I say pleural cavity, who can tell me what that is? Yeah, it's the space around your lungs. So from your chest wall and your lungs, you have this space. And because, like when you take a breath and breathe out, there's movement there, right? And we don't want friction. There's usually this little like thin liquid there that kind of allows for that the lungs and the chest wall to just move seamlessly. Now there can get a buildup of fluid that gets infected, and it can cause that infection can cause friction on your lungs there. It usually, this is another one that's a secondary process. It's not something that you just have pleuritis. It's usually from something else. Maybe you have pneumonia or TB or some other thing happening with your lung that's causing you to have this fluid buildup and causing this friction to happen. So you're going to usually have a sharp pain, a lot of times on inspiration. Why would there be a sharp pain? Exactly, there's that friction. Your lungs are kind of sticking to the chest wall, and it causes that pain, especially when you inspire, because that's when you're kind of first starting that movement of the chest wall. A lot of times, patients are not going to want to take deep breaths. They're going to have very shallow breathing because they don't want to move that chest wall so much. We're usually, just like in any infection, we're going to see fever, elevated white blood cell counts, probably a friction rub. You guys listen, you guys done lung sounds in lab,
Yeah.
you know, the friction rub. It's kind of that coarse, like that's not the right sound, but it's kind of like a deep, like almost like a little flapping almost. And it's that chest wall and the lungs kind of catching a little bit. With this, we're probably going to do chest x-ray, do some labs. They might do vital capacity, not very often. Usually the chest x-ray is going to show some of the inflammation around there. We're usually going to treat the cause, right? It's caused by something. So we're going to treat that cause. We might give them some pain medication just to help them with breathing. I want to be careful though, because if we're giving them opiates or narcotics, what's one of the side effects of that? It suppresses the respiratory drive. They're not going to be breathing as much. And when the respiratory system is already compromised, we want to be really careful. It may collapse the lung. We'll talk about pneumothoraxes a little bit later. I skipped over. Okay. Pleural effusion. So that's something that's actually a little bit different. That's where you have the fluid that really builds up and compresses. That fluid doesn't absorb the lung and it can eventually push the lung to collapse it. It can be either transudative or exudative. So transudative is more of just that serous fluid. It's just fluid that's kind of building up. It's leaking out from the cells and the capillaries. The exudative, that's the infection that's causing it. I think I just gave you the answer to the question. I've done that. So the exudative, it's got all those white cells and usually some not so nice drainage. And so the cause would be, right, exudative is usually infection, where the transudative, it's just kind of that, I would say the serous fluid. Why would you have transudative? I kind of gave you the answer with exudative being infection. What might cause transudative? Why would there be fluid leaking out from their cells? Could be trauma. On the right track, too much fluid. Right. What would be too much fluid, like around the lungs? Maybe We're gonna talk about cardiac in a couple weeks, but think about the blood flow through the heart. If you have congestive heart failure, that fluid is gonna be backing up into the lungs. And so then too much fluid is gonna be leaking out, and that can cause that fluid to build up. So heart failure, sometimes liver and kidney disease can cause that fluid to back up as well. And then usually with the exudated, you've got things like pneumonia, tuberculosis, sometimes cancer will cause other things to build up. Same type of general respiratory signs and symptoms. We're usually going to do a chest x-ray and we might do a thoracentesis. Do I have a picture of the thoracentesis? I don't think I do. How do I not have a picture of a thoracentesis up here? Let's find one. Alrighty, so you have somebody sitting up, usually have them sitting up at the bedside. Oh, why aren't you opening? Oh goodness, is this gonna get too big? All right, well, you can kind of see it here. So here's kind of a picture of the lung. The lung has this fluid, right? Pleural effusion, there's fluid that is built up down here. Now, because it's at the bottom of the lungs, that makes me think gravity is involved. So what kind of effluent is probably there? It's probably just from excess, I mean, maybe. I'm thinking it's probably the transidative. It's probably just from heart failure or something like that. Okay, so then you can kind of see they put a sterile drape or something on here. They clean it off. And then there's a little needle. See that guy's holding a little needle. And they usually will use an ultrasound and they'll look and make sure that they're in the right spot where they want to be. This would be a medical provider. This is usually a doctor, sometimes, occasionally, I don't know if a mid-level provider like a nurse practitioner or DO could, or a PA could do it. But they put this needle in, they access that area where the fluid is collected, and they hook it up. Usually there's little glass bottles that have negative pressure, and those glass bottles will pull out that extra fluid. And that is called a thoracentesis. Usually the little stick hurts a little bit, but they typically will numb up that area with some lidocaine or numbing agent. No, in fact, most people say they're pretty relieved because remember it's pushing. See how it's pushing in on this lung field? And so as that's drained out, their lungs can actually expand and they report a lot easier time breathing. Sometimes we'll reposition them a little bit, have them move a little bit to try to get the rest of the fluid out. There's not a needle that's left in there while it's draining, kind of like we do IVs. We haven't done IVs yet in the program, but you know, you insert it, it has a little needle and you slide a catheter off of it. So all that's left inside when you do an IV is just a little thin plastic catheter. That's the same thing for the thoracentesis. Okay, so now we know what thoracentesis is. There we go. All right, so where did my clicker go? We want to figure out what caused it and treat that. We might do a thoracentesis. If it keeps building up recurrently, we might put in a chest tube, which we'll talk more about that in a little bit. So pulmonary fibrosis, that's another restrictive disease. That's one where you have fibrosis or scarring that happens throughout the lung tissue. So in that, it's not that we have something pushing in on the lungs, like with the pleural effusion, it's that the lungs aren't able to expand and contract normally because of that scar tissue that happens. It usually happens because sometimes people have a hereditary, like it's a genetic thing, they're more prone to it. Sometimes a virus or some sort of occupational chemical exposure can cause that scarring. Sometimes you can have immune dysfunction. My mom has this. She had a liver transplant 25 years ago. And so she's taken anti-rejection medications for 25 years, a really long time. But because of that, the anti-rejection medication, it's suppressing her immune system. Because of that suppressed immune system, she's actually developed a few autoimmune diseases, one of those is the pulmonary fibrosis. And so she has several lung disorders or, that she has to kind of battle because of that. We're okay with it because she's alive. She had cancer in her liver and bile ducts. And so I was 12 years old, I think. That's when I knew I wanted to be a nurse. So I knew the nurses when I took care of my mom, like we knew it was going to be a good day when we had certain nurses taking care of my mom. And so that cancer, she had chemotherapy and radiation, and it killed the cancer, but it also killed her liver. So that's why she had to have the transplant. And so we're okay with things like pulmonary fibrosis. I don't love it because, it impacts her life. It's pretty hard on her, but she's also alive because of this transplant. So we kind of figure it's a trade-off of, she has a new liver, there's things that come with it, but I'd rather have her alive and here with the pulmonary fibrosis. Yeah.
So virus.
Yeah. It's more that a virus might cause scarring. It might cause damage to the lungs. Yeah, good question. Signs and symptoms, usually progressive dyspnea, right? Because that scarring doesn't happen overnight usually. It's something that's happened. And so generally that scarring gets worse and worse. So people get a little bit short of air and then more and more as time progresses. They usually have a chronic cough, they're fatigued. They might have some clubbing. What does clubbing look like?
The fingernails.
Yeah, the fingernails. It's kind of like a thickened fingertip area, and the fingernails kind of come over. And that's a sign of what? Yeah, chronic hypoxia, chronic low oxygen levels. So we might give them some different medications to help with lung expansion. We're going to really encourage these people to quit smoking, especially because they already have scarring and damage to their lungs. Smoking is just going to increase that. We want to make sure they are up on their vaccines, right? Because they're a higher risk of having some issues with that. And then eventually there could be lung transplants. There's not a whole lot of people that are great candidates for that. And it's a pretty iffy procedure. So you're not going to see a lot of people with that.
My aunt had a double one.
Really? And she's doing okay?
But she had to go in like 3 times. So the third time was a charge where she actually. Yeah,
Yeah.
I'm doing fine.
Yeah,
She
awesome.
had, COPD.
But doesn't smoke anymore, right? Good.
Right.
Save those
Yeah.
new lungs. I
I
mean, that's some of the things like people on transplant lists. They will like do all kinds of tests and things because if you're online for a new lung and you're still smoking, they're like, no, thank you. We're gonna go to the next person because you're just gonna, wreck that new lung. Atelectasis. So that's where you have, your alveoli. So your bronchial trees that come down and spread out and you have your little alveoli where the gas exchange happens. That's where those little alveoli kind of collapse or partially collapse. So a lot of times it can be hypoventilation. What are some scenarios where people might have hypoventilation, which is, they're not breathing as well or expanding like they should? Intubation? Right. Yeah, that could be one. Sorry, I was making sure I heard that correct. So intubation could be one. Why else are we not breathing very deep? Opiate toxicity. Yeah, maybe they have some medications on board. I'm thinking surgery. A lot of times, especially after abdominal surgery, people do not want to breathe very deep. Usually we'll hear these fine crackles. What are those crackly sounds? Right, but what's happening inside of our lungs? The alveoli are popping back open, like they're partially collapsing. And then as they take a deep breath, those alveoli are popping back open. And that's what you hear is the crackles. Oh, no, sorry. So think about a semi-hard plastic ball that kind of gets like partially pushed in. And then you breathe and it pops open. Yeah, it's not like perforated or anything. It just kind of collapsed a little bit and we're popping it back open. Usually those should stay mostly open, those alveoli, but when we're not breathing very much, they can become partially collapsed. So you want to make sure, that's why we teach the coughing and deep breathing, trying to keep those alveoli open. They're gonna have diminished breath sounds, right? Because if they have atelectasis, they're not moving air in those alveoli. So we're not gonna hear a whole lot in it. We really want them to cough and teeth breathe. We're gonna have them use incentive spirometers. We really want them to ambulate. Why do we have them ambulate? Exactly, right? We're gonna be breathing deeper. We're gonna be having bigger breaths the more we're moving. The big issue with atelectasis is that we're worried it can progress into something else. What are we worried about progressing to? Yeah, pneumonia. Our surgery patients, when we're looking at postoperative patients, we are worried that they might be developing atelectasis, which means they're not opening up those lungs, which does make them more risk of developing pneumonia, some sort of infection there. We talked about restrictive disorders or we talked about some of the nursing interventions. Oh, I guess I gave you a break early. Okay. Another one. Okay, so let's talk about obstructive disorders. This is where you have either an airway obstruction or sometimes you can't exhale appropriately. So something is causing where air is not moving in and out as well as we want it to. I like this kind of Venn diagram because it shows that COPD, when you say that somebody has COPD, it's kind of an umbrella term for a lot of obstructive disorders. So you might have chronic bronchitis, you might have emphysema, and you might have asthma. You might have somebody that only has one of those that could be diagnosed with COPD, or you might have somebody who has asthma, chronic bronchitis, and emphysema, or one of the two. So when you hear that somebody has COPD, just know it's kind of an umbrella term. It means there's some sort of obstructive disease that's happening. And it might be good to find out a little bit more. Do they have a history of asthma? Do they have a history of just maybe emphysema, something like that? But it's that airflow limitation where they can't get the air in and out like we want them to. So here's a little picture of our lungs, and you can see like this is normal up here. Here is the bronchial wall. That's this tube right here. Normally, it's really thin, and the airway inside is nice and open, and air can flow in and out. And then here we have along with chronic bronchitis. So that's where this bronchial wall, see how that pink area, that's the wall. It's just swollen and inflamed. It's restricting the airflow. And a lot of times with chronic bronchitis, you have this mucus that builds up. And so that restricts the airway even more. Because of that, look at these alveoli. What's happening? What's that? It's like it's inflamed, and it's also getting air kind of trapped in there, right? They're finally able to get some air in, and the air is kind of getting trapped inside of those little alveoli. Emphysema. With emphysema, your bronchioles are pretty well open, but these alveoli, you have even more air trapping that happens, and they build up and lose the elasticity. They're not able to expand like kind of normal alveoli should kind of move and fluctuate. We don't want them to collapse, but they should be moving some. Here, they're just getting so big and they lose so much elasticity. It's like having these stretched out balloons at the end, and they're not getting airflow back and forth. So that's why sometimes we call them pink puffers and blue bloaters, you'll see. Is this my picture? Oh, it is. Yeah. So with chronic bronchitis, sometimes they call them blue bloaters. They tend to be a little bit bigger. They a lot of times end up being a little bit blue because they're usually hypoxic. With these people, they usually have a lot of sputum and cough. Like with their cough, they have a lot they're coughing up because those alveoli, the bronchioles are getting really thick and they're getting a lot of sputum that's in there. So that's what you'll see with the chronic bronchitis. The people with, where's the other one go? I thought I put in here with my emphysema. I guess I didn't. All right, well, we'll get to emphysema in a little bit. Or, I have it in here. Let's go. So these are all in your week resources. And I have week 6 and 7 just all the same because they're all lots of they're all respiratory. Here we go. Emphysema, the pink puffer. So usually these guys are a little bit thinner. They're not kind of as large as the blue bloaters, the bronchitis. They usually have thin extremities and a barrel chest, right? Why do they have that barrel shaped chest?
They'll feel like.
Yeah, the alveoli have lost their elasticity. They're trapping all this gas in or air in, and so their lungs are actually getting bigger and bigger, causing the chest wall and the rib cage to kind of expand out and become this like barrel chest to accommodate all that extra air. These guys do a lot of pursed lip breathing. They do it naturally because they realize that helps them keep the airways open. So they're like, they're doing a lot of that. A lot of times these guys will speak in like short sentences. And yeah, that's probably it with that. Okay, where'd I go? All right, so back over here to our chronic bronchitis, blue bloaters. This one I think is the COPDers. So that could be emphysema or chronic bronchitis, right? Just general COPD. I like this picture because I love how it's got this guy and he's like leaning over a desk. Why do our patients with lung disease lean over like that? Yes, it expands their chest and rib cage, allowing for more lung expansion. It's so typical to see people who have respiratory issues. You're going to notice they're going to be doing what they can to like lean over. I noticed when I had pneumonia, I would be at my kitchen counter and I was like, just give me a minute. And then I was like, oh my gosh, I'm like a walking like example of like respiratory issues. You know, a lot of times you will see these patients who are on oxygen and still smoking. So there's some good education we need to do with these people, right? Because oxygen is very flammable and cigarettes are a direct, you know, source of fire. So emphysema, they lose that elastic recoil on their alveoli walls. It causes that air trapping. And when the air is all trapped in there, they can't get as much new air in to then be able to exchange the oxygen and carbon dioxide like we want to. Oh, here's my emphysema guy. I did put it in. Okay, double dose. Here's a little picture of the air trapping. You can have some of this mucus in there and see how the mucus, it's like a valve almost. As they breathe in, it lets the air into the alveoli, but then it's like that valve that like kind of stops and clogs it up from leaving. Boop-a-doo. So a lot of times people with COPD, regardless of kind of the bronchitis, emphysema, a lot of times smoking, either active smoking or they've had a lot of secondhand smoking or from the environment. There's been a lot of chemical exposure. There might be a family predisposition. I really like this little graph. Is it this one? I think there was one in your book that I liked even better, but just talking about effects of smoking and if we can educate our patients about quitting, right? Because if you quit smoking, oh yeah, I don't like this one. I mean, it's okay. But it talked about, do you guys remember the picture in your book? And it had like a path, like a road. And it talked about, you know, after one day of smoking, you have something is better. And after a week and after a month, it shows you how like after, was it a year, your risk of cancer in your lungs goes down by this much percentage. At 5 years, it goes down by this much. It's really impactful. And so if we can show our patients, so look in your book for that road. If we can show our patients, you know, yes, you might have been smoking for decades, but if you can quit, you can have changes in your body that can start today and that will keep changing and keep improving and making you health or getting you healthier every day from them. Bum, bum, bum. We talked about that. We talked about that. Oh, one thing with the bronchitis, you're more likely to see wheezing and crackling. Why is that? Why would we hear wheezing with bronchitis versus emphysema? Yeah, it's that constriction, right? The bronchioles are swollen and there's all that sputum there that's causing that constriction. When we hear wheezing, think constriction. wheezing, it's kind of like a musical instrument, right? It's like air is barely able to escape, and so it's making that little high pitched noise. So complications of COPD, core pulmonology, basically just saying heart failure, right? These people can develop heart failure because of the stress that the lungs are going to put on the heart. They might have weight loss, and they might end up having a pneumothorax, which we're going to talk about a little bit later in the day, which is the complication. Yeah.
So, I mean, I understand that COPD covers like the whole bronchitis. Can somebody just have? No.
Yes, but you could still say they have COPD.
Okay.
Yeah. It's just that it's just an umbrella term to use. It's an obstructive disease. Because if you think about it, COPD is chronic. Wait, obstructive pulmonary disease. So it's some sort of respiratory or pulmonary disease that's causing chronic or long-term obstruction. So that could be emphysema. It could be bronchitis. It could be asthma. It could be somebody develops all three of those. Yeah, Sharita?
So my aunt, she lost a whole lot of.
Yeah.
But she's on dialysis.
Mhm.
4 times a week now.
Yeah.
What effect does that have on the kidneys? Is it correlated or?
The one with the liver transplant or the lung transplant?
Well, not so many two separate.
I think they're two separate things. I mean, our system, especially some of our bigger systems like your renal system and respiratory, they can have an effect on each other. But I don't know. I think we have to look into that a little bit more. Yeah. So diagnostic test, chest x-ray, CT scan, kind of what we were talking about earlier. With this one, we do want to do ABGs, right? Because we're concerned about the airflow through the lungs. We want to make sure this person is, they're not hypoxic. They have enough oxygen. We want to see if they have any carbon dioxide or anything else built up in their system. Therapeutic, we're going to do a lot of supportive care. These diseases are not reversible, right? So COPDs, they're something that you develop and you can improve. You can kind of maintain, but I'm always going to have asthma. I'm not going to ever get rid of it. I can maintain it and I can do things that are going to keep my lungs more healthy, but it's not something I can be cured from. So COPDs are what? COPD diseases, that's kind of the wrong, I don't know how to say it. These umbrella diseases can really affect people's life, and because they're not going to go away, and there's a lot of different levels of severity, we want to work on making these people as comfortable as possible and helping them with the quality of life. Okay, these are people who they might have that activity intolerance, right? They can't walk from here to the other side of the hallway without taking a break. We're going to help teach them what are some things we need to do to help you maintain your life. Kids typically will have asthma maybe, and usually you develop COPD bronchitis or emphysema later in life.
So if the doctor says, oh, you have asthma, it's very
Oh.
controlled.
So sorry. Occasionally, there can be a childhood onset of asthma, so that does get better as they age. So thank you so much for clarifying that. So with asthma, and I'll talk about that in a little bit, there are times that as people can have asthma, and you can develop it when you're older, you can develop it when you're a kid. There are times as a child, they can have asthma, and as they grow, they can actually outgrow their triggers or what's causing the asthma. This pulmonary rehab, it's just for patients with obstructive disease. Sometimes we have them in programs. We're like, hey, how can we get your lungs functioning the best as possible? Let's check and see how your oxygen is when you're walking. Let's try to see if we can increase this amount. What things can we do to make you healthier? So asthma. So that's when your bronchial mucosa, or kind of like the lining of the bronchioles, gets really inflamed, and then you can have spasms of the bronchioles. You can get air trapping, kind of like with emphysema, where you get the air trapped inside those alveoli, often from that spasming or from the inflammation. It's usually, it does say usually reversible. Thank you for bringing that up. As a child, it's usually reversible. A lot of times, like I'm actually adult onset asthma, and that's just from allergies. I have lot of allergies. And so from that, I got lucky and developed asthma from that. Your airways can actually remodel similar to bronchitis and COPD. There can be hereditary issues with the asthma, like some people are just more prone in their families. But if you have airborne things, pollution, smoking, that can also contribute to it. There can be a lot of triggers to asthma. Usually when people have asthma, there are certain things that are going to trigger them or cause them to have asthma attacks. You know what I'm saying? You know, having asthma attack. That could be if they're exposed to something like smoking or different scents. If they get sick, like I got sick and my asthma was really irritated, which probably helped me in developing my pneumonia that I got. Stress. So sometimes people with asthma, they start having sometimes these spasms and bronchoconstriction, not from anything outside, but internally. Their stress hormones actually can trigger a asthma attack. And then certain medications can also trigger asthma attacks. It's really important that we can help teach these patients with asthma, know your triggers. Yeah.
Why would they? Trigger
Great question. Well, especially when we talk about like cardiac, there's certain medications that actually work on things in the lungs. So like your ACE inhibitors actually work, they go through the lungs. That's kind of part of the system that they, it's the angiotensin, not to get too off track, but how the medication is metabolized and moved through the body. So patients with ACE inhibitors, so getting your blood pressure a little bit lower, sometimes one of the side effects of that medication is they'll have a chronic cough because it's stimulating that part of the lungs. Like it's working in the lungs. That makes sense? A little bit. We'll get more into it in cardiac, but just know there's certain medications that as they work and move, we're interrupting signals or changing things at different parts in the body. And so if that's involving the lungs, that can actually trigger asthma attack. Yeah.
So can you develop them as you go? Like,
Yeah.
and then like, maybe another one she can probably have.
Yeah.
And she always gets attacks, from outside.
Yeah, so
What is that?
sometimes sudden shift in the air, either temperature or humidity, things like that, that can really cause an issue. Like I went out for a date with my husband as I was still recovering, and we went to a restaurant. I was doing good, but it got really cold outside while we were in the restaurant, and I walked outside, and that cold air just triggered an asthma attack. And I spent the rest of the ride home just trying to survive. So of course, I didn't bring anything like I should have with me. I'm a really bad patient. He was like, "Oh my gosh, you're dying," and then he started to like hit me on the back because he thought I was choking. I'm like, "Please don't! Like, you're killing me." But yeah, the change of like temperature and humidity in the air can also affect and be a trigger. So your signs and symptoms, you're going to be short of breath. They're going to be wheezing because there's that constriction. A lot of times there can be a cough. So think about that bronchospasm that people have. It's going to be causing cough. And it can be worse at night too, especially think of positioning as they're laying down. That can put more work on the lungs. So one of the complications, status asthmaticus, usually we see this more in kids than people with adult onset. And it's where you have a severe, like just continual asthma attack. Usually patients will have their albuterol inhalers, you know, that they're using, but it's not working. Or they don't have their inhaler with them, right? And they're just not getting air in. Because they're not exchanging air, they're getting hypoxic. And eventually, when we talk about acid-base balance, because the hypoxia and the acid-base balances are imbalances, they could even die. So this status asthmaticus is a critical diagnosis. It's something that if we see somebody with that, we're going to be treating them really aggressively. Thank you. Yeah, there's a kid at a basketball game last week that started having an asthma attack, and so I was like, I'm just gonna go to the bathroom. Let's see how he's doing, because he was like, because I mean, I don't know, maybe those help, like, what are they called, the people who are at like those games, the trainers. I'm like, maybe that trainer is good, but I don't know, like they know how to like wrap an ankle. I don't know if they know how to make even airway. So they did a good job though. He got his inhaler. He did fine. But it can be a serious thing if you get triggered with asthma. If you can't stop that attack from happening, you need to end up seeking emergency care. Yeah.
So when kids are having this type of asthma, that means you get a
Nebulizer, they might, yeah. Anybody who's got kind of that constriction, usually will start off if they have a rescue inhaler with the albuterol, they'll use that. Sometimes it's just not effective enough. And so you'll need to have a nebulized treatment, which have you guys learned how to do those in foundations? Yeah. And so that's just a more longer sustained way of getting the medication. So if you think about think about a kid with status asthmaticus, right? Probably little, probably fighting for his life, trying to breathe. What kind of position are they going to be in? They're going to be sitting up. They're usually kind of like this. They're trying to open up their chest. They don't even know it and they're doing it. Usually, especially if they're thin, you can see them using their accessory muscles in their lungs and or not lungs, between their ribs. So when you have so much constriction with that asthma, that rescue inhaler, how far is that one medication, that one puff going to go? Right? You're really constricted. It's probably not going to get very far into your lungs. So we put the medication in a nebulizer, which kind of humidifies it and mystifies it, and so as you breathe it in, it gets, maybe this far. And then as it kind of helps open up a little bit, it's going to get a little bit further. As it keeps opening up, it's going to get longer and farther into your lungs to be able to open up more and more. With that being said, let's go back to me for a second. All about me. So I had two different inhalers after my pneumonia. I had my albuterol inhaler, and then I also had my Flovent, that's the inhaled steroid. Which one do I take first? Albuterol. Why do I take the albuterol before the Flovent, the inhaled steroid? It actually opens up the lungs, right? Because if my lungs are a little bit constricted and inflamed, that inhaled steroid is it's not gonna get all the way through. It's only gonna get to that top part. So I wanna take the albuterol, and then I usually wanna wait a couple minutes. Usually about 2 is what's recommended. And then, once you've given that albuterol just a little bit of time to open up that airway, then you go ahead and do the Flovent or the inhaled steroid, or whatever other kind of inhalers there are. So if you have a patient with inhalers, you want to start with the dilators. Things are going to open it up, give it a couple minutes, and then do the next inhaler. You have a question? Say again? Oh, the albuterol will always be the rescue. Yeah, because the albuterol is what you're opening up your lungs with. The inhaled corticosteroids, those are maintenance medications. That's just something to help keep, steroids are always I guess you could give it IV, like you're giving it as a rescue type medication. But generally the inhaled ones, you're just giving that to maintain the symptoms. You're just trying to decrease that inflammation. So rescue inhaler is always going to be the albuterol inhaler. Yeah, good question. Anybody else have a question? Miss a hand? Okay. Sometimes they'll do some allergy testing, either skin prick testing or blood testing for these patients to try to see if they can figure out what they're allergic to, maybe figure out what triggers there are. Spirometry or peak flow meter, they don't do this anymore. So if they just ask you a question about it, we're going to have patients do peak flow meters. And that just, maybe in kids, they might do this, and that just kind of tells you how far, it's a little meter and you blow into it and it helps see about your lung capacity. If you do it every day, same time every day, it kind of gives you a trend, just like we do daily weights to see about our fluid status and our fluid balance. With this, they just don't do it anymore for adults. Really, when they're checking for symptoms and how somebody is controlled, they just say, hey, how often do your symptoms affect your life? And how often are you using your rescue inhaler? Typically, if somebody's using their rescue inhaler more than, gosh, I want to say 3 times a month is the current one. Not for exercise. If you know you need it for exercise, that's a different category. But if it's no, I responded to a trigger or something happened where I need to use my rescue inhaler, That's what people use to check management of symptoms. So if Davis asks you, we want our asthmatic patients to use a peak flow meter. In the real world, you're never gonna see these for adults. Moving on. Here's a peak flow chart. Again, use these. Maybe in kids, if you work with peds, they might have you do it. And it just has, like, you put what time of day it is, and the green, yellow, and red zone, that's just saying, like, green zone is I'm good, I'm breathing well, I'm doing fine. Yellow is maybe I'm just not feeling so great, I feel just a little bit tight, a little short of breath, and red is I'm really having trouble, I need to use my inhalers, not doing so well. We're gonna have them do bronchodilators. There are some long-acting bronchodilators. We a lot of times want them to have leukotriene inhibitors. You guys know what leukotrienes are? Our body produces them in response to some sort of allergen or some sort of trigger that we get. So for me, I'm really allergic to dust mites of all things. Those little tiny microscopic things really get me. And so I take a leukotriene inhibitor, I do singular, because that helps decrease my body's response to these dust mites that live everywhere. So that can help people stay controlled. Whatever is triggering them, that's going to help decrease their body's response. They might do corticosteroids, either inhaled, like the Flovent, or it might be oral as well, if they need kind of either short term with a certain illness, or they might even have long-term steroid use if they're just really inflamed overall. They might need oxygen occasionally. All right, so moving to cystic fibrosis, which you guys talked about a little bit. This is an exocrine gland disorder. It's usually has a strong, it's a genetic component where both parents have to be carriers of this gene for the child to develop cystic fibrosis. I say child because typically, 10, 15 years ago, people didn't live longer than childhood with cystic fibrosis. It affected their lungs so much that they would die. Now we have adults who are actually living with cystic fibrosis. Our treatments have improved. People are doing a lot better with it. It's characterized by these thick, and copious amounts of sputum. That's our biggest goal with these guys, is just keep their airway clear because they're just producing so much. They also, because it's that exocrine gland, they have these blocked pancreatic enzymes. And so they're also going to have some GI issues as well. A lot of times they have diarrhea and other issues. It's always hereditary. Oh, here's a little picture of a kid or a person. So here their body is like over excreting sodium. That's one of the symptoms of it. There used to be this Kiss Your Baby campaign, and if you kissed your baby and tasted salt on your lips, then they said they'd bring your baby into the doctor to get checked, because these babies, it's hard to diagnose at the very beginning. And so we knew a lot of times these babies, they're excreting so much salt that they taste salty. And so they're always wanting to eat salty snacks. They're always hyponatremic, or their bodies typically are, and so they're craving salt. They're wanting to eat it a lot. They have this dry cough. They have a hard time coughing up these secretions. So a lot of what we're trying to do is get these secretions out. They probably are going to have that finger clubbing even at a young age, because this disease affects them when they're really young. They're going to have this fatty, foul-smelling stool because they don't have those pancreatic enzymes that are going to help break down the fats and other things. They often can get infections. Oftentimes it's getting better, but a lot of times these kids are in the hospital so much, they could develop these infections, antimicrobial resistant infections, and there could be death from that. So usually if we're suspecting cystic fibrosis, they're going to get some testing, specifically the genetic testing. There's going to be a sweat chloride test, right? It's going to test the sweat to see if there's that sodium and chloride in there. Excuse me. What we're really going to work on is first keeping them hydrated. We want to get those secretions loose so we can get them out and so we can get air in. We're probably going to give them some medication. They might even get inhaled mucolytics to help break up all that mucus, those thick secretions that are there. We're gonna have bronchodilators, expectorants. CPT is really big on these kids, that percussive therapy. We're gonna be teaching parents how to help those babies and those kids break up all that mucus so that the kids can cough it out. We really want to work on preventing infection. They're on a lot of antibiotics because they tend, with all that mucus that's just stuck in their lungs, it can get infected. And so they tend to get more lung infections. Yeah, there's a lot of medications they're going to be on. I'm not going to test you on these. Eventually, these guys could get lung transplants as well, because their lung will give out. I think it's from the anti-inflammatory effect. Okay, so looking back at some of the diseases that we've looked at, emphysema, chronic bronchitis, asthma, pleuritis, which would be a restrictive disorder? Got a lot of answers. I like this. All right, pleuritis. So obstructive, remember COPD is the obstructive diseases. That's where something's obstructing, or like the swelling inside, that's considered obstruction. Restrictive, that's the pleuritis, or where you have like the fluid that builds up outside the lungs and is actually restricting your ability to like expand your lungs. So glad we covered that one. And I think this might be the end. We're at the end of the presentation. Okay, do you guys need like a quick stretch break? Yeah, okay. Let's just do like 3 to 5 minutes. Because we're gonna come back and have an activity. So like 37 after, yeah? Okay. When you come back, I'd like you to break up into groups again. All right, so this Minty 136516. Okay, once you're in, if you could give me a thumbs up or like emoji so I know you guys are in the Minty. Oh, I gotta present it, huh? There we go.
Oh,
It's still there. What?
different code.
Different, yes. 136516 Okay, see if I'm in here. Anybody still looking at the code? Not so much. Oop. All right, so complications and cancers. Anyway, so just breaking it up, we're not going to talk a whole lot about cancers. Really, it's more about the complications that can happen with respiratory issues. So we talk a lot about pulmonary embolisms. We're talking about planning care for patients, especially as you guys go to acute care or long-term care for your clinicals, because these guys aren't moving around a lot and we're always concerned about a pulmonary embolism. So it's a blood clot that goes into that pulmonary artery. Where do I have it on here? Where does it usually come from?
Your leg?
Yeah, it usually comes from a DVT or deep vein thrombosis that forms in your legs, usually from lack of mobility. People aren't moving around. It causes impaired gas exchange, right? Because it's blocking blood flow. And people are pretty ill with this. It's a very acute illness or sickness. These patients usually need immediate treatment. This is a nice little picture that kind of shows up here where this blood clot has come and it's just like wedged itself. So depending on the size of the blood clot, if it's smaller, it might travel deeper into the lungs. If it's bigger, it might kind of wedge itself somewhere else in the larger part of the lungs. Wherever it kind of wedges itself, is there going to be blood flow past this place? No. So beyond that spot, there is no air exchange. So it really depends on where that lung is kind of blocked off at and how much of the lung is blocked off to some of our symptoms. It's usually a DVT from our legs. It could be a fat embolism. Remember from musculoskeletal last term, which which bones? Yeah, femur, maybe or pelvis. Those bones have more risk of having a fat emboli. So we're always looking with those types of fractures to see if there's a fat emboli that's broken off. Also in labor and delivery, there can be amniotic fluid emboli. So that's something I think you might talk a little bit more about labor and delivery. That's going to be more with maternal care that we'd be monitoring for that. I won't be asking about that because that is not my area of expertise. So prevention. How do we keep people from having this, right? We want them up and we want them moving. We want to keep the blood flow going. If we discover there is a DVT, there is a blood clot in the legs, we want to treat that or at least diagnose it right away so we know what's going on. For patients that are high risk for having a DVT, a lot of times we'll give them anticoagulants. What type of anticoagulants? Like what would be an example? We might give them warfarin. That's more of a long term. I'm thinking more heparin. Yeah, because heparin is usually more of a short term med because hopefully these patients aren't going to be long term like immobile, right? Maybe it's just after surgery in the hospital. Yeah.
So is that considered a clot buster?
No,
What is a clot buster?
that would be a thrombolytic. So, and if you break down the word, right, thrombo or thrombus, that's a clot, and lytic or lysis, that's what breaks it up. So those are given in acute care settings, usually in the ER or ICU. And if you have somebody who has a pulmonary embolism, maybe a clot that's traveled to their brain or heart, they might give them thrombolytics that go and break up those clots. There's a narrow window of time when you can give those, and there has to be certain conditions met. I'm not going to go into thrombolytics for this, but they are different than a blood thinner or an anticoagulant like heparin. What are some other things we do as nurses? What are some nursing interventions we do to try to help prevent DVTs and PEs? Yeah, I want to ambulate our patients.
When I use stocking.
SCDs or TED hose, the compression stockings. Heard something. We might give them heparin. What about our hydration status? If we're more dehydrated, we're more likely to form blood clots. So we want to make sure we're helping to promote hydration for our patients. Was this a question? I don't know what this is. Oh, this poor guy, he looks bad. A pulmonary embolus. So if you see him, you know, he's got this little blood clot that kind of traveled up here. He does not look good. He's got some heparin, actually has IV heparin that they started for him. Heart rate is pretty high. Sometimes these guys will be coughing up blood, or sometimes what I've seen in the clinical setting is like frothy pink sputum. And that's just kind of the blood coming out there. I have a question next for you. I can't remember. Oh, I just asked you. Okay, just tell me, what are some signs and symptoms of a PE? short chest pain, tachypnea. That tachypnea, does that happen just gradually or how does that present?
Sudden.
Yes,
Sudden.
sudden. It is usually all of a sudden they are fine and the next moment they're not because what happens? That clot moved, right? They were doing okay, but that clot just started blocking off part of their lung. And so it's very sudden. They might have some cyanosis, chest pain. You might see some crackles in there, that pink sputum. Usually their heart rate will go up. Their blood pressure is probably going to go up. Their oxygen sats are probably dropped. They might even have absent lung sounds, right? If it's blocked off a large part of the lung field and there's no airflow, or no, pardon me, there's no blood flow getting through, it's gonna, eventually those cells or those alveoli aren't gonna be able to do what they need to do. And so we're not gonna have good airflow. Oh, and they're gonna have a cough. Their body is gonna think, I need to like move this around. They're gonna be coughing and trying to move things. Diagnostic test. D-dimer is a serum lab test. It's in your blood. It tells you, essentially, it's checking your body's response to clots. So if your body is producing clots, it produces this little thing trying to break up those clots. A D-dimer checks for that. So D-dimer doesn't tell you that you have a DVT or a PE, but it says you probably have some clots in your system. So it's just one thing that kind of points us towards that direction. If the D-dimer is high, there probably is some clotting going around somewhere, like abnormal clotting. A spiral CT, that's one that we use specifically looking for pulmonary emboli. I don't know why they call it a spiral CT. There's probably a real reason. Usually what I've seen is an angiogram, and that's where they go in, just like we talked about cystogram earlier this term with that dye going in and then looking at the bladder and the kidneys and everything. This is where they do the dye, but they're looking at our lung perfusion. What they're doing, and sometimes it's called a VQ. They do a ventilation perfusion scan, or they call it VQ. I don't know why it's VQ. Anyway, but they look at with that dye, they send it through. So they're looking at the blood flow through your lungs, and they're also looking at the ventilation at the same time. And they're saying, is there a discrepancy? Are we opening up lung fields, but then there's no blood flow to that area? That tells us there's probably a blood that's blocking off those lung fields there. Therapeutic interventions. So, like Mickey was saying, we might give them thrombolytics to break up that clot. Has to be within a narrow time window. You have to be a candidate that's eligible or healthy enough to get those. We probably are going to have them on some anticoagulants. If somebody has developed a DVT and a PE, usually we have them on long-term anticoagulant therapy. So things like warfarin or there's some other newer ones. In the immediate care, we're going to be getting them oxygen. We're going to be sending them to all these diagnostic things to figure out what's going on. It says embolectomy. That's really rare when we go in and surgically like remove the clot. It says they might have a jugular or femoral filter. Those are usually called IVC filters. So inferior vena cava. So if you think about our bodies and the blood flow, you know how all the blood from the lower half comes into our inferior vena cava and then feeds into the heart, right? So we're most likely going to form a big blood clot that's going to hit us. It's probably going to be in our legs. That's usually where our body will form big blood clots. So in order to try to prevent that from going anywhere, because besides our lungs, where do we worry about those big blood clots traveling to? Our brain and our heart, right? So we have these things developed called an IVC or inferior vena cava filter. They look like a little mesh umbrella. They go in through usually they do a little stick in the groin, and they put a little tube, like a Foley catheter, right? But it's special access, and they go up to the IVC, inferior vena cava, and they open up this little mesh umbrella. So if this is my IVC, it goes in and it opens up, and it doesn't block the flow of blood. It's just like, it's not mesh like we think like mesh, but I don't know. I've seen them. I don't know how exactly they work, but it has like little metal pieces that help trap any blood clots. So it will keep it there instead of having it go up into our heart and everywhere else. Yeah.
Isn't that just as bad as it traveling? It gets like, you know, you form these spots and it just builds up on this screen.
Right, except for our body has things that naturally will break down those clots.
Okay.
So our body has mechanisms that will break down clots as they form, like when we're checking for the D dimer. That's checking for our body's response that we're sending out this, we're releasing this thing that helps break down clots. So even though those clots do get trapped there, our body will break them down. And the IVC is so big that usually a clot, you know, we think, gosh, it's so like a big clot, but these clots are actually very small. And so our body's usually able to break down those clots very efficiently before they would cause any trouble in that filter. Yeah,
Is that a thing? Is it DK?
there is, I don't remember what it is. I just know when I look it up, I look to see where it is on the level, if it's high or, yeah, I won't ask you. I'll just, for my testing, I'll just say, I might say they have an elevated D-dimer or something like that. Or if I give you a level for the D-dimer, I'll put the range there. Yeah. They are removable, so you can get them in and then get them pulled out. Where did I put my little clicky thing? Oh, well. So pneumothorax. So this is where sometimes people say it's a collapsed lung. Anybody see my little clicker guy?
Right there.
Oh, thank you. I like to move around and I lose things so often. Okay, so there's a couple of different kinds of pneumothorax. I hope you guys just understand the differences of. I'm going to start on the right. So tension pneumothorax. Something happened inside the lung that caused that lung to kind of have I'm saying this wrong. Yeah, so either something in the lung itself had an issue, chronic lung disease, when sometimes this can happen when patients have chronic COPD and their lung tissue is just so diseased, they might have essentially where air is leaking out into that chest cavity. So this is kind of diseased lung, and all of a sudden when you have air leaking out into this space, you know, it doesn't start like this. It usually starts a little bit, and as you breathe in and air leaks out, and then more and more comes in until eventually it's just pressing in, it's compressing all this lung area. Does that kind of make sense? Another kind of pneumothorax would be a traumatic form of pneumothorax. And that's where you have a car crash, a stabbing, like they're showing here, that's very violent. But where you have, it's not the lung that's the problem that has the opening, it's the outside. There's air leaking in from the outside into that cavity. And so there's air that's here that's come from the outside, where on the tension pneumothorax, it's actually coming from the lung itself. There is a spontaneous pneumothorax, which usually happens, it's more from, it's kind of like the tension pneumothorax. The spontaneous pneumothorax, the reason why I like to point it out is because the people who have these, typically, these are tall, thin, young men. And they're just living their life and they're healthy. A lot of basketball players, and maybe that's just because tall, thin young men are like tend to play basketball. I don't know. That's just who I've seen. And they have sudden shortness of breath. Usually one side is really killing them. And I'm like, oh, I know what this is. And they get an x-ray and you can see they've had like their lung is collapsed on one side. So just know, like, if you ever have that person who fits that profile, that's kind of one of those things. Hey, we need to check to see if they've had tension pneumothorax. So when we have a lung that's partially collapsed, fully collapsed, you know, we have all this air, that the air is pushing in on the lung. That's why we can't re-inflate, right? If this person had stabbed, I guess, big enough. No, because the inside of the air is negative. The inside of our chest cavity is negative pressure, right? That's how we're pulling with the diaphragm to expand the lungs. So when you open this up, we lose that negative pressure. And so actually it pulls this air in. So how do we treat this?
You stop it with my favorite.
Yeah, well, first you want to stop it. You want to like stop air from getting in. And yeah, you put something over it, but then how do we get rid of that air? You have to drain it. Yeah, a lot of times we would do a chest tube. I have a question here. What do I have here? Oh, here's a pneumothorax. So it talks about, it could have a ruptured air sac. So that would be the not traumatic, the tension. That'd be like a tension pneumothorax. They might do a thoracentesis to pull out air or fluid. Usually they're going to do a chest tube for these patients. And I don't think I have it on here. Let's find a chest tube. So the ones your book showed you was okay. I think it was more like this. I mean, maybe 50 years ago. I don't know. I've only seen ones that look more like this. And this will be hooked up to the patient like this. So generally you'll have your insertion point where they went in and inserted into that area. Usually if they can, they'll either use a CT machine to guide them or they'll use an ultrasound to guide, make sure they're going into this space that actually has the air, it's open. Then you'll have your tubing that comes down and let's find a better picture of the chamber. I don't know. It's just so full. I don't like it. Okay, we'll just go here. Okay. Atrium are really common chest tubes to see in most facilities, but you'll see other ones, they all work the same. Why can't I get to this? Okay. Oh, thank you. Accept the cookies. I wish that I could get a Girl Scout cookie every time I accepted cookies. I feel like it's only fair. Okay, why is this so small? You guys. All right, can you guys see this?
Can you write the picture?
Open image. Thank you. Gosh, I feel like an old person. That's what my kids tell me. They're like, Mom.
The next one.
Hey, okay, that's
right.
okay. So in the book, it had separate suction and water seal. Most chest tubes you're going to see today are going to have the suction and the water chamber or the water seal kind of together. So here, up here, this blue thing, that's going to be the port that connects to the patient. So you can kind of follow it down. Right down here is where there's going to be water. Water. I think that's the one that connects to the patient. Maybe this. Oh, actually, this is the one that connects to the patient, this long one. This up here is the suction. So you can have these chest tubes and they can be hooked up to suction, or they can be hooked up to nothing and it would just be to just drainage as it allows. Most of the time, they're going to have some suction on there to try to pull out whatever's in the lung. The reason these are combined together now is because you have this section that's already set up here. And here's the water seal. Why is a water seal important? Or why do we have the water seal?
We can go back in.
Right, otherwise we just kind of expanded like where the flow of air is gonna go. And it's just gonna, as we breathe in and out, it's gonna go. So if somebody has a pneumothorax, they have a bunch of air trapped in their lungs. And we've put a chest tube in. If this is suctioning through here, what are we going to end up seeing? Actually, the suction will come through here. Yeah, we'll see bubbles. Often as they breathe, as they're breathing, we're going to see that suction pull of that air out. And we'll see a little bit of bubbles through here. It's going to be intermittent bubbling as we're pulling it. Very common to see idling with chest tubes, and that's where this water level, and they color it with at least the atriums. Most of them have a colored water or liquid, so you can see it better. If it was clear, it'd be really hard to see. But you're going to have tidling, which is a fluctuation of the level of this water, and that just shows as you're breathing, the pressure changes. And so the pressure as it's changing in our lungs, as we're breathing, we're going to see a little bit of pressure changing here in the water level, and that's called tidling as it goes up and down. Sometimes you might have a continuous bubble. There's like constant bubbling through here. What could that be from? Yeah, it's usually a leak. If it's air coming from our lungs, like I said, like if we're getting rid of that pneumothorax, it's going to be an intermittent bubbling. Like as we're breathing and expanding those lung fields, it's going to be pushing more of that air from that cavity out. But if we have a continuous bubbling, that makes me think there's a leak in in some of the tube. And so with that, we just kind of go check. First we look, we inspect, kind of like with our assessment with our patients, right? We're looking all along the tube. We don't see anything. Then generally what we do is you get some hemostats or clamps and you just start clamping. Some people say start at the bottom. Some people say start at the patient. Either way, I usually start at the patient. I'll take my clamp and I'll clamp kind of close to the patient. And I'll say, is it still bubbling? Well, that means the leak is somewhere down here, right?
Right.
And then I go down further and I clamp. Still bubbling? Okay, it's still down here. And I keep going down until I pass that area, and that tells me where the leak is. Before I would do that, I always check the connections, right? Because if you have a loose connection, that might pull some air in too. So save yourself a little bit of time and always check the connections. Over here, this is the collection chamber. You can see how, where was, this one's like all full. Like this chest tube is ready to be changed because they have filled it up from here and it spilled over onto here and spilled here. See how the numbers go up? Like they start at 10 mils here and then they go to 30, 40, 50. So usually people have chest tubes for several days. Occasionally I've seen them fill up pretty fast, but usually after the initial one that's filled up, they kind of go pretty slow. How would we know how much output came out for our shift? Yeah, we have to mark these. So back to this guy here, typically what you want to do at the very end of your shift is go to your spot. Like let's say it's filled up to the 600, right? My end of my shift, I'm gonna take a marker and I'm gonna mark a little line at 600 and I'm gonna put the date and time. And then I'm gonna go back and say, okay, maybe it was marked at 400 for the shift before me, so that I can see, okay, it was at 400, now it's at 600. How much came out during my shift? 200 mils. Really important that we mark these because these aren't ones that we can empty to see like how much is there. It all stays inside of here. Okay, any general questions about chest tubes? Yeah.
So you said, like in the last picture where it was also the.
Yeah. Yep.
So you just put on a whole new one of these?
Yeah, so here's the tube. This is the tube connected to the patient right here. Oh gosh, I'm getting confused here. I think it's this one, yeah. And so you just unhook it from this chest tube here. There's a clamp. You clamp it, unhook it. You open up a new chest tube, you get it from the supply area, and you put it right, and you just hook it back in. So you don't have to get a whole new chest tube. It's just the container. You're just hooking up a new one. And if you don't know how to do it, that's okay. Have I told you guys? Have I told you guys my mantra? 1 second. If you don't know how to do it and you don't know what to do, what do? Ask somebody. It is okay to be nervous. You are going to be nervous and you are going to be scared. Just don't ever be nervous alone, right? There's so many resources for you. Know who those people are and go ask them. And maybe like you come to me and I'm like, ooh, that person is tall and thin and they have sudden shortness of breath and I don't like that. That makes me uncomfortable. Their oxygen stats are dropping. Let's go figure this out, right? We're both going to be nervous, maybe a little bit. We're going to be nervous together looking at it. Okay, Mickey, your question. Oh, great question. Usually they're kept on the floor because we want it dependent, right? If we have it, even with suction, if we have it like higher up, they're still going to have to fight gravity. So typically chest tubes are going to be on the floor. It's probably kind of hard to see, but there's a little foot that comes out here to make sure that it like stays flat and doesn't tip over. If you have to transport your patients, what do we do? Yeah, I want to hook it on the bed, but still making sure it's dependent. It's lower than the area of the chest tube. All right. Good bunch of chest tubes? You're going to be nervous about them, but it's okay. Oh, and I totally forgot, you guys. I didn't remember till 10 o'clock last night. Crepitus with people with pneumothoraxes, right? You have all that air that's in your lung space. That air has to get out somewhere. If we put a chest tube out, that's going to help it get out. Our body will naturally start essentially like diffusing that air to get out. And where does it go? It goes actually through our tissues and it's trying to get out. And you have these like tiny little air pockets. It usually goes, I'm kind of doing this because it follows like it's gravity, right? It's like up usually. And so you have air that's trying to get out. And so if you push on that area, it's called crepitus and it feels like little Rice Krispie treats. Like, just like it's just the weirdest, coolest feeling. I've felt it maybe 5 or 6 times. It's not like super common, but every time you feel it, you're like, oh my gosh, this is so cool. And then you're like, where are the students? Who are the new nurses? Everybody come feel this because it's so interesting. But it's just so interesting. So if you ever have a patient you're worried about a pneumothorax, or maybe they have a pneumothorax and they have a chest tube or something, you're always going to be checking for crepitus. Usually it's up in here because it's kind of like where like gravity, like where it's going to go to eventually. Sometimes on the back, depending on where they're laying, but it's a really interesting thing. And it's a term that you're going to need to know. Okay, moving on. We talked about tension. They might do an ultrasound. Ultimately, the first thing they're probably going to do is an x-ray. Might do a chest tube. They're probably not going to do a paralysis tube. Okay, so rib fractures. Rib fractures are going to be a lot more, probably one of the more common things that people experience. And it can be from any kind of trauma. Think car accident, fall, somebody's assaulted, sometimes people can cough hard enough that they fracture their ribs. Usually that's in older people, especially maybe I think my little old ladies with osteoporosis, their bones are kind of porous, but it can happen. Also CPR, right? If we're doing effective CPR, we're probably going to be breaking some ribs. Not that that's what we're trying to do, but that's just CPR is traumatic. And just to remind everybody, we're only doing CPR on dead people, right? If somebody is to the point where they need CPR, they are already dead, right? There is no pulse, they are not breathing. So doing CPR that's very aggressive and looks really tough, that's not like, oh, I don't want to hurt them. Like, well, no, they're already dead. Okay, they're already dead. We're just trying to maybe see if we can bring them back. That's just my little 2 cents. So our care for rib fractures, we want to help control pain. We also really want to work on breathing because it's gonna hurt when they breathe. So what might be a complication of these patients with rib fractures? They might be sad. What's a complication we talked about a little bit ago? What about atelectasis? Where our alveoli are going to be partially collapsed because we're going to be taking really shallow breaths. We don't want to breathe very deeply. It used to be the treatment for rib fractures that we would wrap up people's chests. We'd put like ACE bandages around because that helps. That support kind of helps with the pain. What it also does is restricts the respirations a little bit, and it makes people more prone to atelectasis, makes them more prone to have pneumonia and things like that. So we don't actually wrap them up anymore. We really want to encourage coughing, deep breathing, all those things that's going to make them feel uncomfortable and hurt, which is why we try to help promote some of the pain management piece. Flail chest is when you have multiple rib fractures, because if you think about now, if I breathe in and out, my rib cage is kind of supporting that whole thing. Flail chest is when you have, usually it's a trauma that's happened. So I think about somebody in a car wreck, maybe they were driving and somebody broadsided them, they hit them. This whole part of the chest was hurt. All of these ribs are broken now. And so as I breathe in and out, those ribs are actually moving almost opposite of what normally, like as I would breathe, they're just kind of moving independently from the rest of the chest because they're not attached anymore. They're just broken. Those people, they're pretty, pretty ill. A lot of times those have significant injuries other than even the flail chest. Usually they're going to be in the ICU. They usually need to have mechanical ventilation, partially because they can't take adequate breaths without having kind of all the muscle and bone coordination like we normally have to breathe. So acute respiratory failure. This is when somebody comes in, usually they come into an ER or urgent care and they can't breathe very well and they deteriorate pretty quickly. This usually, I would say somebody with our COPDs, or somebody like in a nursing home who aspirated and they just have sudden respiratory failure where they just cannot manage maintaining their airway or maintaining their oxygen saturations. They need some assistance. So with these people, we're going to see that they are breathing a lot more with more difficulty. They get confused, their oxygen sats are going to be dropping. They can eventually go into a coma. Okay, and then we're going to talk about acute respiratory distress syndrome. So that's a little bit different than acute respiratory failure, because with acute respiratory, I put that wrong. So acute respiratory failure, we want to treat the underlying cause. Might be intubated or sedated. So with acute respiratory distress syndrome, that's usually not people who are chronically ill. So people might have acute respiratory failure and they have COPD or something like that. People with acute respiratory distress syndrome is usually people with healthy lungs that are struck by a virus. Like I think a lot about our COVID-19 patients, the ones who are healthy, they got COVID-19 and it attacked their lungs and they got sick really fast. Those would be acute respiratory distress syndrome. So it's not that it's its own disease, it's more of how our body responds to something else. If that makes sense. Gonna have a lot of the same signs and symptoms. There's a big death rate with these patients because whatever is causing them to be sick, have these respiratory illnesses, is usually significant enough that it causes mortality in about 40% of people. So we really want to treat them very aggressively and promptly. We're going to do all the usual diagnostic tests. We want to really determine the cause. What has caused this respiratory issue? They're probably going to be intubated. We want to treat whatever the cause is, give them some antibiotics, supportive care, maintain their pressures, and really just try to get them through. Kind of like with COVID-19, right? We didn't have a treatment for it. We just had supportive measures to try to get people through until their body could start maintaining on its own. Okay, cancers, so exciting. So in your lungs, you're going to see 4 different types of cancers usually. Small cell, large cell, adenoma, and squamous cell. I'm not going to go into asking you specifics about the different ones. I just want you guys to kind of know some generals with lung cancer. Smoking. I know I feel like I'm talking about this all the time, but when we're talking about respiratory, smoking is such a huge risk factor for so many diseases, especially with the lung cancer. 80 to 90% of lung cancers are directly related to smoking. And so that's, when we're looking at patients' histories, that's something that's really important. Some signs and symptoms. So a lot of times, especially if you have smokers that have a chronic cough, they might not have signs and symptoms that we recognize until later and the cancer is developed. They might have recurrent infections. A lot of times we look at this anorexia and weight loss. Anorexia meaning they're just not wanting to eat. They're not very hungry. They're losing weight without trying to. That gets concerning. They can have some complications because of the tumors. Sometimes they can have pleural effusion, so that fluid that builds up. Superior vena cava syndrome, that's just when if the tumor is blocking the superior vena cava, then all that blood that's coming into the superior vena cava is getting blocked from getting into the heart. So things just kind of fill up and you have like JVD and some like edema in your upper extremities, but not your lower extremities by the tumor. Sometimes you can have these tumors that will secrete some hormones. So they might have some hormone imbalances and they're trying to figure out why do they have these hormone imbalances? And it might be from tumors. We're gonna do regular diagnostic tests like we would for anything, but we're also gonna add on probably some biopsies if they can find like there's a nodule or something like that. They want to test to see what kind of cancer it is, because depending on what kind of cancer, that's gonna direct what kind of treatment they need. Here's kind of a gnarly picture of like a cross section of a lung, and where the arrow is pointing to is actually a tumor. We have to stage it. Actually, we don't stage it. I'm so thankful. A pathologist will stage it. And they'll kind of say, or actually, I think it's the oncologist stages it. They'll say like what stage it is, lets you know how, and staging is based on a bunch of different things, where it's at, how invasive it is, different things like that. The higher the stage, the more likely it's going to cause morbidity and mortality. A lot of times they'll use chemotherapy and radiation to try to help control. They might do some lung resections. So you can see where here there's a cancer like up in the upper lobe. This is called a wedge resection, where they just take out like a little cheese wedge. Really similar. This is called a segmental resection. Up here, they actually took out a whole, or down here, they took out a whole lobe. So depending on where the cancer's at, if they need to remove it, they're going to try to remove as little as possible and keep the healthy lung there as long as possible. So if these patients are going to have surgery, we're just looking at them to try to, like most surgery patients, we're going to teach them what do they expect, what do they want to know afterwards. We really want to include family, and we want to let them know they're probably going to go to the intensive care unit because we're doing some major work in their lungs. They're probably going to need some supportive ventilation and other things while they're recovering. They probably got some chest tubes. I don't like this one as much. Sorry. All right. I want to look at this the IS bar with you guys. Actually, I don't know. Do you guys want to do IS bar or do some scenarios? Okay, let's do scenarios. All right. Hold up. Go back to your groups that you were in. And you know how last week we did some scenarios and you guys had to choose, like, you had to guess which other group scenarios they built? We're gonna do the same thing. Okay, so how many groups do we have? Raise your hand if you're the main person of a group. I know. Okay, you guys are a group. Then you guys are a group. You guys are a group. You guys are a group. Do you have a group? Where's your group? There. Okay. Wait. Okay. 1, 2, 3, 4, 5, 6, 7, 8. Okay, I have 10 diseases though, guys. This is gonna be so hard. I have to. All right, so I'm gonna point to a number when I come by your group, and that's gonna be which scenario you need to create. So remember, very broad, very general. As a suggestion, let's just say this person's coming into the office or to the ER or something, and just give a brief scenario, and you're describing one of these. And then as a group, when we're done, you will all guess and we'll see who's right. Okay? All right. Looking, oh my God. No.
Where's your group range? What are we doing?
Oh, so we're
So remember, just a very brief scenario. If you want to, you can include lab tests, signs and symptoms, history.
So first, what's the brief scenario?
Yeah.
Here, I'll write it.
Brief scenario.
You do chest X-ray. How much is was signing for you? Yeah.
Right, everybody pretty much done with their scenarios? I think so. Okay. All right, let's do some scenarios. Okay, so let's make sure we're listening and giving good attention. What I'd like to see is once people have given their scenario, as a group, talk about it and then hold up your hands with like whatever you think it is. And we'll look around and we'll see, okay? And then they'll tell us who's right. So anybody want to go first? Yeah, okay, in the back.
16-year-old male with ED after experiencing shortness of breath after maintaining the first half of the passport. The respiration was shallow and rapid, and he said his experiencing chest pain as half the breath now.
Ooh, all right. So talk with your group. What do you think the scenario is? Okay, I don't see these guys. What are you guessing? 8, 8. 8, 5.
Was it 8?
8. 1. Ooh, an outlier. Okay. All right. So what do we have? 8. So pneumothorax. And I'm guessing which kind of pneumothorax were you trying to say it was?
Oh, yeah.
Spontaneous. Spontaneous pneumothorax is usually in thin, tall young men. Yes, nice job. All right, anybody want to go next? Okay, this group over here. All right, let's make sure we're giving them full attention.
A 35-year-old woman went to the ER living with distress and struggling to breathe. She presents with rapid salivary and persistent cough and used exemplary MedSurg treatment.
All right. So thinking of that scenario, talk with your group. Which disease or illness do you think we're looking at? Do I see a 4? Maybe a 5? You guys? I mean. Okay, what number was it? Number 5, asthma. All right. Okay, who wants, you guys are next?
Yeah.
Okay, then you guys will be following. All right,
Patient comes in.
hold on one second. There's lots of, just a second. There's lots of chatter and I have trouble hearing, so I'm sure people far away have trouble. So go ahead.
Patient comes into urgent care experiencing anxiousness, showing signs of tachypnea, tachycardia, cough, and thoracic chest pain. Upon oscillation, we found crackles and friction rub.
The plural friction rub.
For 8 or 6.
Okay, so with your group, I hear 3 or 7, 1, 4. You're right. 7, 1. All right. What do you guys say back there? 7. Okay, what were you guys? It was 7. Okay. I don't know if you have a pulmonary, like a friction rub with embolism, but you would have definitely those other symptoms. Oh, does it? All right, cool. Follow the book. Okay. All right, nice job. Okay, middle group, you guys are up.
George Glass is 80 years old. He's a long time smoker and presented in protest. Chronic cough and he's lost 80 pounds in the past 4 months. Oh, yeah, sorry, he's 80 years old. I'm so sorry.
Hold on,
For the last 2 months, the saturation.
Number 10. He didn't say space, right?
All right, I hear 10. Anybody else? 4. 4. Not. It could be any. 4. Okay, what do we have? 4. COPD. Oh my God. Good job for the COPDers. You guys are next. That's okay. All right, so let's hear the group in the back right.
Okay, so we have 65-year-old male who walked into. We have a 65-year-old male who walks into the emergency room, just returned from traveling abroad. He's been, has complaints of coughing up blood, loss of appetite, voice hoarseness. They ordered a chest x-ray and bronchoscopy. They skipped it. Vitals are 130/94, 101, our temp is 101.6. Respiration are 24 and his O2 is 91%.
Okay. I see a lot of 2s. 2. Are you doing 1 or 2? 1? Got a 1 and a 2? 1.5 back there? All right, so what do we have? Tuberculosis. All right. You guys are next? You guys already went? Yeah, so then we're gonna do the front group and then we'll move over to you guys over here. All right, Rena, let's hear it.
We have a 10-year-old boy brought by her mom to the ER. The boy presents with chronic sinusitis with thick and tenacious secretion. The mom said that the kid lost appetite and that the stools usually smell really bad. When he kisses his kid, his sweat tastes salty. What is it?
I see a lot of sixes. Yeah, all right, what were we?
It's sick.
Six, cystic fibrosis, kiss your baby.
Yeah, kiss your baby.
Okay, who wants to go first? You guys will? Okay.
A 60-year-old woman presents today, is complaining of chest pain and persistent cough with a bloody fever. And she said that she was surprised to find out this morning that she had lost 10 pounds in the last 2 weeks. She claims to have stopped smoking 1 year ago. That was serum test was done and there was evidence of a clone cell.
All right. So what do you guys think?
Yes.
I see a lot of tens. Tens? All right, what is it? 10? Good job, you guys. Yep. Okay, one more group, all right? Okay, I mean, now we've narrowed it down to just a few choices.
Patient has been 4 days post-op, now his practice and reasons for hospitalization due to surgery has not been mobile. Test on our x-ray, sputum, and culture and CBC. Patient has 101.6 and less 10 speed.
Respirations?
No, sputum. First, Tim. Yeah.
Oh. Ooh, what do we have?
One.
Yeah. I'm gonna say one.
I see a lot of ones. One. All right, what do we have? Okay, nice job, you guys. We're at the end of class, so if you don't mind, fill out your L's of your learn, like just hit 3 or 4 highlights. What did you learn today? And don't forget to submit it. Oh, really quick announcement. Next week is test number 2. It covers diabetes, chapter 40, the respiratory, like overview 29, and then lower respiratory, which is 31. I'll be putting out a study guide with questions and such for you, so look out for that. And then there were questions about the group project. That's going to be during week 8, so the week after next. So 2 weeks from today, you have to be here in person. It's an in-person group project. If you are not going to be here, please reach out to me so I can give you an alternate assignment.
2 weeks from today.
2 weeks from today.
That President's Day?
19. Are you gonna teach the date?
Oh.
That's 2 weeks.
Maybe it's week 9.
Oh.
That's there's something, it says here is next. Oh,
Hold on.
give it to Sheena. Oh, Sheena.
Oh, sorry, it's week 9.
Oh, okay.
Week 9. There is an assignment that says due this Friday. I'm changing that. It just got labeled wrong. I apologize.
That's here.
So the group project, just so you guys all know, there will be something assigned to you guys to do in class. You'll be working together. And then afterwards, you need to write a reflection based on that has very specific prompts. There's a rubric on that assignment, so please look at that so you know what's expected of that reflection. I'll change the date.
No.
It's in week 9. Yes. All right. Thank you guys so much. Yeah. Probably tomorrow. I just haven't made it yet.
In the module. You need to go to the calendar, it's like, in the 9 or something like that. It's on the very top, do today.
I'm moving it right now. I'm so sorry. I just looked to see where it was at.
I was just gonna say,
Paper natin.
Yeah. So I think good.
Oh, you feel like you're doing more like group work?
Yeah,
or-
it's like how I was like telling you the other day, like, I really like this because it actually makes sense.
Mhm. That's so good.
Just, I just had to.
Thank you. I really appreciate that.
Eh, kasi kung saan wala namang extra.